colleagues, I want to tell you about initial experience with the sinusoidal trifocal IOL, Acriva Trinova. I have several implantation, and this I want to mark the important design features on this IOL. Natural spectral filter IOL with champagne color. It's very important. And diffraction relief with a sinusoidal profile gives 3 diffraction maxima suitable for imaging, minus the first, 0 and plus the first orders. Other maxima of higher orders have very low intensity and unsuitable for practical application. More than 90 effective light transmission to retina, and it gives outstanding visual outcomes in mesopic conditions. I implanted 16 IOLs with phacoemulsification after 1.8 2.0 millimeter incision. Bilateral implantation was performed in 7 patients, 14 eyes, and unilateral implantation for 2 patients, including 1 eye after myopic LASIK. The main preoperative measurements included optical and ultrasound biometry, keratometry, corneal topography, aberrometry. It's for anterior segment of eye. And of course, check the fundus and OCT of retina. The optical biometry we made with IOL Master 700 to get the emmetropia for both eyes, if with the implantation in both eyes. We measure astigmatism and choose the patient with astigmatism less than 1.0 D to check with Sirius and Pentacom system. We measure aberrometry, and we don't need to do pupillometry because the diffraction optics design, there is no dependence of the size of the pupil. The principles and formulas for calculating Trinova IOL depending on the axial length of the eye with an intact cornea. I used Barrett Universal 2 or Haig's formula for all my cases, excluded the case with post-myopic LASIK eye. Principles and formulas for calculating Trinova IOL depending on the axial length on the eye after refractive surgery. I use Haig's L for post-myopic eyes, not for after radial keratotomy or hypermetropic LASIK. And the data on the slide. I want to share with you one case of my implantation. This is my doctor. He has father and mother, and I treated both of them at the same time. Both of them got the trifocal lenses. Father got the sinusoidal lens, and mother got the typical standard trifocal lens. And so father got the excellent vision at intermediate distance. He uses PC and laser, and he works with computer a lot of time during the day. He got the good vision on mesopic condition. His driver, halo effects almost didn't bother him. Comfortable night driving, he noticed reading distance. He said that some farther than mother. The reading distance is 35-40 centimeter, and uncorrected visual acuity for each eye 1.0. Mother is not a user of computer, and she noted the good vision at intermediate distance, but not perfect. Satisfactory orientation on mesopic condition, reading distance some closer than father. She noted halo effects, but not painful. She does not drive a car. And the first couple of weeks with visibility in blush tones, but she got the uncorrected visual acuity 1.2 for each eye. The diffraction relief with the traditional shape edges profile gives only 2 diffraction maxima suitable for imaging 0 and plus of the first order. The third peak with the design with a shape edges profile is in principle impossible to obtain lenses with such profile. Cannot be trifocal in principle. The loss of the third maximum has to pay for the increase in light intensity in the remaining 2. We can see the data of barometry and contrast sensitivity of the patient with Trinova. So the law of conservation of energy cannot be deceived. The change in intensity can be compensated by an adequate change in the sensitivity of the retina, and the loss of the third maximum cannot be compensated by anything. A questionnaire survey of patients with Acriva Trinova confirmed patient satisfaction with the results of the operation. A patient with a trifocal artificial lens is able to see well in the distance, drive a car, reading a book, and watch TV without glasses. One more interesting thing. One patient works with television cameras, and he said me that he can see the pure white color, the perfect white. He said me, I know what is the white color. It's the very, very clear white color with this filter lens. And due to this filter, we can advise this lens for artists and this kind of patients. With sinusoidal lenses, there are no complaints of hard halos at all. So exclusion criteria are the same like multifocal lenses at all. It's irregular astigmatism after excimer laser correction with small optical zone and dilated pupil, high mountain, high order and spherical aberrations, ectopia lentis, glaucoma, optic nerve atrophy, and high myopia, hypermature cataract with unexpected biometry. It's not good for patients with Fuchs dystrophy, central corneal opacities, amblyopia, wet AMD, diabetic retinopathy, and macular edema. But yesterday we saw the case with epiretinal membrane. The doctor treated patient with trifocal Trinova, and then he did the he showed how he did the vitreous surgery with peeling of epiretinal membrane with good results, and perfectionism of the patient. So, who can be a patient? Patient with a small pupil, because pupil size is not matter, with anisometropia, dry AMD, astigmatism, which is irregular, amblyopia, and diabetes, stable diabetes. No, we can see the perfect centration of this lens in my patients. So we can use this lens after LASIK with glaucoma, stable form of glaucoma and mature cataract. So there is no universal solution. Take into account the patient's desire to give up glasses. What is the facilities and benefits of this kind of treating? One all to treat cataract and refractive disorders, no need to adapt to different implant system, stable results without the use of the capsular ring with moderate uniform ligament defects, uniform stretching of the capsular bag, ensuring stable refractive results after surgery, wide range in diopters, a smaller number of restrictions in the selection of patients, the concept of smart family, the independence of the pupil size, quality of near focus, middle focus, and far focus. One implantation is a sufficiently extended intercapsular bag in the center of the capsular bag. Wound assistant technology we can use with 1.7, 1.8 millimeter. We can use two-step surgical technique. Different size of we can implant this lens with less than 23rd diopters across the 1.8 millimeter over 1.24 diopter, more than 2 millimeter. Careful removal of viscoelastic, and I use the meiotic injection in the end of surgery a little bit because it's useful for capsular bag tension distribution and the absence of IOL deflection. I noticed that this lens can some deflect from the back without viscoelastic. It's useful for get the equal strength of the back and right position of the IOL. With a significant defect of the ligamentous apparatus only with the intercapsular ring. The recommended size of capsular axis is 6 millimeter. This is feedback from the patient with text. Recently, I began to notice that my vision gets worse. My vision became blurry, so I decided to change this situation. With the help of internet, I found a clinic. Due to reviews of patients, here I get achieved to implant multifocal IOL Trinova because I drive a car and work with computer. I had surgery 2 weeks ago. Firstly on the left eye, then on the right. I feel very positive. After the surgery, when I opened my eyes, I saw the world as a never new one through the new lens. When I drive a car, the halo effect is almost absent. And so the goal of all surgeon, all surgery, it's high patients and doctors' satisfaction, high quality of life, no restrictions at different light levels, no restriction on physical and visual activity, quick recovery, stable refraction, and visual acuity, and we can get it with this IOL. Thank you for your attention. Maybe some questions for me. Thank you very much.